Hi, I'm Sarah and I'm a speech pathologist in the Complex Care Hub at the Royal Children's Hospital in Melbourne, Australia. With my colleague Rachael, who's a dietitian, we are presenting today our decision-making pathway for tube weaning. Here are our disclosures. We work with a complex medical patient group and we're part of a multidisciplinary team who work with children and their families. Patients need to meet a strict criteria to access the hub services. For example, complexity is defined by the patient having over 10 appointments across a minimum of 3 specialty teams within a year.
Our complex feeding service is a dietitian and speech pathology outpatient-based team. The pathway enabled us to triage our large patient caseload of about 180 children, as within this group there was a high demand for tube weaning services. Our service focuses on the development of oral eating and drinking skills, whilst also supporting growth. Initially, we developed family-led goals targeting the child's feeding development and pace our therapy based on the child's skill progression. We offer face-to-face and telehealth appointments and phone reviews, and often find a mix of these suits most families well. The tube weaning decision-making pathway we are sharing with you today was developed as a result of our collaborative work over the past 5 years.
Our decision-making pathway starts with a swallow safety assessment. Having dysphagia or an unsafe swallow does not prevent us from progressing down the decision pathway, but it will determine whether we are aiming for a complete tube wean or a goal that involves some oral tastes alongside enteral feeding. If swallow skills are emerging or modifications are indicated, then I will do a period of intervention targeting these skills before we move to the next step in our pathway. I use a range of functional therapy approaches where the aim is to demedicalise feeding. Using family mealtimes is often a great way to commence feeding therapy, as it's an already established within their household routine, and we're not asking families to do more when they often have a high care demand with their child.
The next step in the pathway is to assess the child's growth. Are they growing well? Yes, great, we'll move forward. But if there is poor growth, I'll adjust or increase the enteral feeds to prioritise growth in anticipation of initial weight loss, as is expected at the start of most tube weans. We talk to families about the benefits of the feeding tube provides, in that we can support the development of oral skills whilst maintaining a good nutritional intake and good growth. We see children who have an adequate nutritional intake and subsequent good growth make gross and fine motor developmental gains, and this leads us to progress through the pathway towards an active tube wean. We next determine if there are any upcoming surgeries that may impact on the child's nutritional intake. The nature of our patient cohort means this is a very real possibility. Surgeries such as cardiac repairs, transplants, cleft repairs, tonsil and adenoid removal, and airway reconstructions all have significant nutritional impacts post-surgery, and having a feeding device can be beneficial during these times. These surgeries can also be disruptive to a feeding therapy, and to delay therapy until after the recovery is often the better option.
The final consideration in our pathway is the time of year. Here in Melbourne, we have hot summers, so we avoid this time of year due to an increased risk of dehydration in the hot weather. It's also a time of year where there are holidays and families may have more difficulty getting in touch with their usual medical contact at the Complex Care Hub for advice. We tend to delay tube weaning during the middle of winter, as it's peak virus season for our medically vulnerable patient group. Once we've gone through all the considerations along the pathway and made interventions as clinically indicated, we start an active tube wean with the patient and family. Thanks for listening.